Wonderful. So good morning, afternoon, evening to everyone, depending on where you are in the world. So welcome to this webinar, which we've titled Nutrition for the Micro-Preemie, the Japanese Way. And a very welcome to you all. So I'm Cheryl Battersby, and I'm a neonatologist in London in the United Kingdom and work at Chelsea and Westminster Hospital, also senior lecturer at Imperial College. And I'm delighted to be chairing the session with John Smith, who's on the other side of the world in Australia. And he's a neonatologist at the Royal Hospital for Women in Sydney. And he has experience working in both the UK and Australia. And he has an interest in feed intolerance and necrotizing enterocolitis. So this webinar is part of a very successful international lecture series organized by Julie Oy, conjoint professor at the School of Women's and Children's Health University of New South Wales in Australia. And a real special thanks to her and Rahul for organizing this and the invitation to chair. So why have we got this webinar today? Well, consistently reported in the literature, Japan has one of the world's lowest rates of neonatal mortality and necrotizing enterocolitis. Though the reasons are unclear, it is long known that there are differing clinical practices around the world, and certainly to those in the UK and Australia. And hence today's meeting is really an opportunity to share our clinical practices across the world and also to hear how things are done in Japan. So before we introduce the speakers and start the talks, just some housekeeping. So all the attendees today, you'll be muted on arrival. And please do ensure your videos remain off and that you keep muted. Because of the number of us, we'll have to submit questions by the chat room. So just please ensure you've got that. So the webinar will be about 90 minutes. We'll have 3 talks, and then we'll take questions at the end in a panel discussion, and you're very welcome to join that. So to help the speakers and us, may I please ask for the questions and sentences to be short and easy to understand. And please also remember to add your name and the country you're posting from. So without further ado, I'll be introducing our first speaker, who's Professor SATOSHI Kusuda, who's a neonatologist from Tokyo and director of the Neonatal Research Network of Japan. He has published widely, and today he'll be talking to us about the current trends in nutritional management in Japan. So thank you, Professor, and I'm just going to share your slides.
Thank you, Cheryl. Very nice introduction. So today, 3 Japanese neonatologists are speaking about how we are taking care of micropreemies in nutritional practice. So I just introduce the situation of Japanese neonatal care. So can I have?
Yeah, sorry, just give me 1 second. Sorry, it just stopped working.
So maybe my PowerPoint have some problem. So, oh, okay, thank you.
Okay, hold on. I'll just make that slideshow. Great. Over to you.
So next slide, please.
Hold on. Yep.
Oh, okay. So I'm going to just introduce our neonatal practice for the nutritional support for micropreemies. So my talk is first is a statistical result, and second, I can show the trends in the outcome in preterm infants, and also trends in practice in nutritional management, and also what I would like to express why the nutritional management is important for these tiny infants. Next slide. Next slide. Oh, okay. So 2018, we published the trends in outcomes of preterm infants. And you can see mortality rate is decreasing, and cerebral palsy rate is decreasing, visual impairment decreasing. However, the bottom right, you can see the cognitive impairment doesn't change. So this is the analysis from 2003 to 2012. So what's happening after this? Next slide. So this is the trend in mortality from 2003 to 2018. So mortality is still decreasing, looks decreasing. Next slide. This is mortality by gestational age. You can see still we have high mortality rate among infants born at 22 or 23 weeks. But after 24 weeks, its mortality rate is less than 20 and going down towards almost 5% by advancing the gestational age. So I think mortality rate is, of course, we have a room for improvement, but it's, I think it's very nice position. So mortality rate is good. Not say good, but acceptable. Next slide. But this is trend in cerebral palsy rates from 2003 to 2018. So you can see it's not dramatic, but you can see the decrease in cerebral palsy rate among Japanese preterm infants. Next slide. This is the incidence of blindness. It's decreasing. Of course, not high, but it's decreasing. Next slide. However, again, if we look at the rate of cognitive delay among preterm infants, you can see it's not decreasing. Actually, it was increased and then seems decreased, but not much. So I would say we do not see the decrease in the rate of cognitive delay among very preterm infants. So why this is happening? Next slide. This is the incidence of NSC or idiopathic intestinal perforation. As Jerry mentioned at the beginning, yes, we do not have a high incidence of NSC. However, next slide. Also, if we look at the timing of enteral full feeding, so this is the trend of the day when the enteral feeding exceeded 100 ml per kilo per day. The median is around 10 days after birth. So not much actually changed during the last 15 years. Next slide. This is the trends in the use of intravenous hyperalimentation. It was increased quite a bit. At the beginning, 2003, this year we started this network database. It's only 30%, but right now, 80% of the very robust weight infants received some kind of hyperalimentation. So it's actually advancing. Next slide. So here we look at the DQ of the preterm infant at 3 years of age. This slide comparing the DQ between infant with and without neck or focal intestinal perforation. It's obvious if infant has a neck or FIP, this kind of nutritional trouble, the DQ is lower than infant without NSC or FIP. Next slide. This slide shows the DQ between infant who received hyper intravenous alimentation and who did not receive intravenous hyperalimentation. So no difference between these two groups. That means hyperalimentation didn't help the improvement of the cognitive development. But of course, this analysis have a bias because this is not randomized control trial. So of course, background risk is different. But anyway, that's not help much. Next slide. This is not good data, but x-axis shows the days at enteral feeding exceeded 100 ml per kilogram per day. And vertical axis shows the DQ at 3 years of age. So not much good correlation, but you can see if establishment of enteral feeding delayed, the DQ seems to be decreased. So that means nutritional status can damage the cognitive development. So next slide. So this is my final slide. So again, mortality rate among preterm infants in Japan is improving. However, long-term outcome of them are some part improving, but if we are talking about cognitive development, it's not improving. Maybe nutritional trouble like NEC and also delayed establishment of enteral feeding may damage the cognitive development. So we think nutritional support could be a next key feature for how to improve the long-term outcome in preterm infants. So nutrition is a very important factor for the total management of preterm infants. So please visit this website for downloading our NICU manual. So you can see how we are practicing in daily neonatal care. So thank you. I'm happy to take questions.
Great, thank you. We'll be taking questions at the end because we'd like to get through the 3 very interesting talks first. And we'll have a lovely panel discussion at the end.
Yeah.
Please do post your questions in the chat. You're muted on arrival. And we have just noted about 151 already of you joining. So very welcome to you all who just joined. So thank you very much for giving us an overview. And I'm sure you're all wondering, wow, those are interesting, trends over time and quite different, maybe the very low NEC rates compared to maybe your country, perhaps you're thinking. And the next 2 talks will really give us an insight into how clinical practice is in Japan. And so I'll be introducing our second speaker, Dr. Isamu Hokuto, who's a neonatologist working at St. Mariana University in Kawasaki City in Kanagawa in Japan. And he'll be talking to us first about parental nutrition for extremely preterm infants. So very warm welcome, over to you. Yep, looks great. I think you're muted. Sam, are you muted?
Okay. So lovely. Can you hear me?
Yes, thank you.
Okay. So let's start my talk. Okay. COI. And this is take-home message. For therapy and total parenteral nutrition for extremely preterm infant in Japan should include the following. Use of high humidity in incubator and water restriction for a few days. Initiate with small amounts of amino acid and lipid. Use of good device for peripherally inserted central catheter, PIC. This is background. The care for baby in Japan. in terms of nutrition and respiratory and circulatory management is different from the practice in Western countries. It is unclear how such difference affects the survival rate of preterm infants. In this presentation, I will talk about initial fluid therapy and parenteral nutrition. However, different centers have their own techniques, which I call their secret sauce, like this. So I will be discussing mostly in the Japanese method added with my secret sauce. First, I will talk about fluid management for extremely preterm infants. Fluid management for extremely premature infants is very crucial, and this is not similar to more mature infants. Because from the acute to subacute phase, immaturity of cardiac function of these infants causes circulatory failure. Immature skin leads to increase in sensible fluid loss. Immature renal function causes loss of electrolytes and polyuria. As such, we need to carefully adjust the fluid volume and its contents, especially in the early period of life. Extracellular fluid volume at birth is greater in extremely premature infants compared to more mature infants. It slowly decreases to adapt to the extrauterine environment as skin permeability decreases and kidney function matures. The main purpose of fluid management during the acute phase is to promote the excretion of extracellular fluid and to maintain a body water content similar to mature infants. Soft landing is important. To do so in Japan, such infants are managed with high humidity and water restriction. This figure shows the transepidermal water loss in relation to the gestational age. The earlier gestation, the more loss of water. To reduce the insensible water loss among extremely premature infants, the incubators are said to have high humidity. Specifically, these infants, 20 to 23 gestational weeks, are placed in 95 to 100% humidified incubator. So you can see the baby in the incubator. And these infants usually intubated so that their insensible water loss becomes almost zero. So you don't worry, have to care about it. Instead of managing in high humidity, the amount of fluid given to the infant during the early stage of life is restricted. The initial volume of fluid for premature infant is 50 to 60 ml per kilo per day in AGA infants. This may be increased by about 10 to 20 ml per kilo per day in SGA infants. We consider this method can maintain blood volume for such infants because extracellular water is returned to blood vessels. So you just focus on the volume in the blood vessels. After the first day, water intake gradually increased to 100 to 120 ml per kilo per day over the next 3 to 5 days. In our hospital, the humidity of the incubator is decreased daily by 5%. However, this varies among centers, as some centers prefer to maintain a very high humidity for a week. This table presents the fluid volume and the set humidity for the first few days. Monitoring the water balance is very important. During the acute phase, water balance often changes rapidly, usually within a few hours, due to hemodynamic fluctuations. This necessitates the constant monitoring of the in-out balance and the SVC and or IVC diameters and cardiac function with repeated ultrasonography, so-called point-of-care ultrasound, and analysis of electrolytes. Changes in these values can help evaluate water balance. From this slide on, I will be discussing parenteral nutrition. Extremely preterm infants are born with lesser amount of nutrients. In addition, it usually takes about 2 to 3 weeks to achieve sufficient enteral feeding for growth. The lack of essential nutrient supplementation after birth could result in rapid metabolic crisis. Therefore, parenteral nutrition should be initiated immediately after birth to prevent these problems. However, there is no clear evidence on the contents and duration of parenteral feeding. The recommended nutrition mentioned in the next slides are based on the ESPGHAN guideline 2018. First, amino acid preparation. Amino acid administration is carried out following international reports. This figure shows the amino acid intake was universally related to protein balance. And cellular function are believed to depend on the continuous supplementation of amino acid immediately after birth. About 3.5 to 4 gram amino acid per kilo per day are transferred through the placenta to be used for fetal development, suggesting that a similar amount should be given via parenteral route. In general, it is initiated at 1 gram per kilo per day and gradually increased to 3 gram per kilo per day over several days in Japan. It is a modest amount compared to the recommended dose. However, in Japan, this is referred to as aggressive nutrition. When I took care of 289-gram infant 20 years ago without amino acid administration, her body weight decreased to 214 grams at 14 days of age. However, 5 years later, when administered amino acid to a 265-gram infant, her body weight increased to 214 days of age. It was really amazing that our intervention was of great help to her. Listed are product name and contents of the different amino acid preparations that are currently available in Japan and the USA. Preamine P is a pediatric formulation, and trofamine and premazole is a neonatal specific formulation. Although they appear similar, trofamine and premazole contain higher amounts of glutamic acid and aspartic acid and tyrosine. I'm not sure that this difference affects the growth of their infants. Next, glucose preparation. The amount of glucose production in the liver is about 5 milligrams per kilo per minute. However, preterm infants tend to have hypoglycemia because of the poor expression of the enzyme related to glycolysis and gluconeogenesis. So such infants require glucose preparation after birth. The initial glucose dose is started at 5 milligrams per kilo per minute and adjusted according to the blood glucose level. During the first 24 hours, glucose homeostasis is unstable, so hyperglycemia may occur even at those doses. If blood glucose exceeds 200 to 250 milligrams per DL, even after GIR has been reduced to 3 to 4 milligrams per kilo per minute, insulin should be considered. Once blood glucose level becomes stable, the ESPGHAN recommends the infusion of 8 to 10 milligrams per kilo per minute of glucose. Next, fat preparation. Fat has the highest ratio of calorie per weight, and essential fatty acids are important in many metabolic pathways. If the caloric supply from fat is insufficient, not only glucose but amino acids becomes the default source of energy. Early administration of fat is therefore recommended. However, in Japan, fat administration is initiated a couple of days after birth. This is delayed because fat administration may affect respiratory conditions and may exacerbate bacterial infection. It is initiated with 1 gram per kilo per day and gradually increasing to 3 grams per kilo per day over several days in Japan. This slide shows the name and contents of the fat products currently available in Japan, Europe, and the US. Currently, only the soybean oil-derived preparations are available in Japan, intralipose. Long-term fat administration may increase the risk of cholestasis due to inflammation caused by omega-6 fatty acid. On the other hand, fish oil-derived preparation containing a large amount of omega-3 fatty acid effectively prevent and treat cholestasis. Omega-Ben. The said preparation is already available in some countries, but unfortunately, it is difficult to obtain inside Japan. I don't have time, so I will cut this part this time. So calcium needs to be replenished immediately after birth. The starting dose is at 30 milligram per kilo per day, eventually increasing up to 40 to 60 milligram per kilo per day. Phosphorus also needs to be administered at the early phase. We sometimes observe hypophosphatemia and hypocalcemia on the day 1 to 2 if phosphate was not administered. It is available as sodium phosphate. As such, this preparation should not be used for a replacement until the sodium level has been stabilized. Usually 24 hours after birth and after commencement of the diuretic phase. Phosphate replacement can occur at 20 to 30 milligram per kilo per day. Magnesium, like calcium and phosphorus, is an important mineral for the human body. It is abundant in cells and plays an important role in enzyme activity and neurotransmission. According to the ESPGHAN guidelines, magnesium supplementation is recommended for the early postnatal period. However, in Japan, most hospitals do not begin magnesium supplementation before 7 days of age. This table presents a summary of the TPN nutrients in Japan and recommend. Sorry? Some problem?
No problem.
Keep going.
Okay. Okay, I'll keep going. Okay. The static dose of amino acids and fat are slightly lower. The same true for calcium and phosphate. And vitamin and trace elements also required for parenteral nutrition. However, please let me skip the detail of these. Oh, sorry. Next, I will talk about the root of the TPN. Because of the high osmotic pressure of parenteral nutritional fluid, central venous catheter is always necessary. How do we select between a PIC or UVC? The catheter can be inserted via peripheral vein even in extremely premature infants. Umbilical vein catheter can be used for infants 22 or 23 weeks gestational age due to skin immaturity. So this is a table for vascular access for extremely premature infants. So over 24 weeks gestational age, we usually use PIC line. So I talk about PIC. In Japan, there are not many devices and medications for infants due to drug lags. However, there is a better product of PIC in Japan compared to other countries, I think. The Agapia catheter kit is only available kit for PIC in Japan, but this catheter has big advantage. Its characteristic is include dual lumen, length is 20 centimeters, outer diameter is 0.43 millimeters, and can be infused relatively high volume. 24 gauge catheter, this one, can be used as an introducer. So it secures the PIC on the dorsal hand of 500-gram infants. Outer diameter of overseas product is 0.63 millimeters or 0.87 millimeter. So 24 gauge IV catheter can't be used. This slide presents the suggested frequency of monitoring among infants receiving parenteral nutrition. I think it's almost same as your hospital. However, most Japanese think measurement of BGA, which includes electrolytes and blood glucose, and CRP is most important value to evaluate infants. So BGA and CRP are performed in NICU by physician, and you can get both results within a minute. This is CRP analyzer, and maybe you know this is BGA analyzer. So there are complications associated with parenteral nutrition. First, catheter-related bloodstream infection. To prevent this, maximum barrier precaution during peak insertion, closely inspecting for color change at the insertion site. Repeated evaluation of CRP is important, as I said previously. And cholestasis, metabolic acidosis, hyperammonemia, and hyperlipidemia in this situation, it may be necessary to reduce the causative contents. And it's very rare, but respiratory deterioration after fat infusion can be seen. So we need close assessment of the respiratory condition and withdraw fat administration if the fat is suspected as a cause of respiratory deterioration. And this is take-home message showing again. Thank you. Thank you for listening.
Thank you very much. Yeah, really interesting. I'm sure many of you on the call now got over 170 now on the call, including our seminar room, hopefully at Chelsea and Westminster Hospital. Perhaps you'd like to just reflect on how those differ to your practice, and please do post some questions or even comments in the chat to share what you do. And certainly I spotted about the lipid, and there'll be a good discussion at the end. So moving on to our third speaker, I think this is a really topical area. I'll be talking to us about enteral feeding. And certainly, this is an area that with much debate and even controversy over the use of donor milk, probiotics, glycerin suppositories, and speed of feeding. So without further ado, I'm going to introduce Dr. Tokyo Miyazawa, who's a neonatologist working as a lecturer at Showa University. And he has a research interest in nutritional care for preterm infants. He'll be talking to us about those topics. Thank you. Over to you.
Okay, thank you. So I'll start. Dr. Hokuto, can you stop the sharing the monitor?
Oh yes, can you please?
Sorry.
Yeah. Wonderful,
Sorry,
thank you.
Can you see?
Perfect.
Okay. Okay, so thank you for your introduction. So I'm Tokuo Miyazawa from Showa University. Today, I will talk about...
Sorry, can I just interrupt? Sorry, can we just mute everyone else who's not speaking, please? Thank you, there's background noise. Thank you.
Can I start?
Yes, please.
Okay. So I will talk about enteral nutritional management that we usually perform for extremely preterm infants in Japanese NICUs. So enteral nutrition is thought to be one of the factors affecting the development of necrotizing enterocolitis in preterm infants. So this graph shows the transition of frequency of NEC based on the database of NRN Japan, and that covers about 60% of very robust weight infants in Japan. The incidence of NEC has been around 1.5%, and it is known that the frequency of NEC is lower in Japan than in other countries. This low incidence of NEC is thought to be one of the reasons for low mortality rate of preterm infants in Japan. However, the poor prognosis of NEC is the same as in other countries. It has been shown that NEC has a high morbidity and mortality rate in early preterm infants with gestational age of less than 25 or 26 weeks. and neck is one of the important issues in Japanese preterm infants too. The management of enteral nutrition is extremely important because it may affect not only the development of neck, but also neurological outcome and physical growth of preterm infants. So in 2020, the Japan Pediatric Society has released a policy statement of enteral nutrition for preterm and very robust infants. This statement emphasizes that mother's own milk is the optimal nutrition for preterm infants, and that donor human milk should be the next option when mother's own milk is not obtainable or sufficient. It also mentions about exclusively human milk-based diet, which uses mother's own milk or human donor milk that is fortified with human milk-borne fortifiers, not cow's milk. I will talk about EHMD at the end of my talk. Excuse me. Until 3 years ago, there was no official human milk bank system in Japan. As of 2015 survey, unpasteurized donor human milk was used in quota of NICUs in Japan. And in recent years, there have been several reports of infections such as cytomegalovirus and resistant bacteria via unpasteurized donor human milk. And many facilities are currently refraining from using unpasteurized donor human milk. In these facilities, if mother's own milk is not available, start of enteral feeding might be withheld up to 72 hours or more, or artificial formula will be used. In 2017, Professor Mizuno, who is chair of Japan Human Milk Bank Association, and he's also a professor at our pediatric department, established Japan's first human milk bank system in Showa University Koto Toyosu Hospital. The number of recipients is gradually increasing, and in 2020, donor human milk was provided to about 100 preterm infants at 24 NICUs in Japan. And overall, NICUs using donor's milk are still in the minority at this point, and the use of donor milk is expected to become more widespread as a general nutritional management in near future. So from here, I would like to talk about actual management method in Japan. However, there are large center variation even in Japan. So I will talk only about management that is generally accepted in majority of NICUs. In addition, Showa University is conducting some advanced clinical research on nutritional care for preterm infants, especially in the field of human milk fortification. So I will talk about how to manage it. First, tube feeding. Tube feeding is carried out by intermittent administration through nasal or oral gastric tube. According to national survey in 2017, majority of NICU are fed preterm infants every 3-hour interval, and 13% of NICUs use 2-hour interval due to smaller birth weight or prematurity respiratory conditions. The incidence of neck was slightly higher in 2-hour group, but this difference was not statistically significant. Sometimes duodenal continuous feeding is applied in some NICUs for infants with silent aspiration, BPD, or GERD. In Cochrane review, there was no difference in the incidence of neck between slow and fast advancement of feeding volume. Majority of NICUs in Japan practice slow advancement, that is start at 10 milliliter per kilogram per day within 24 hours after birth, and increase daily by 10 to 20 milliliter per kilogram per day up to 114 to 116. There's no consensus on the advancement of feeding volume when large volume of gastric residual was found. But withholding enteral feeding solely based on the gastric residual volume is not recommended because it is thought to be not predictor for neck. Also, we do not have standard consensus as to whether enteral feeding should be withheld during blood transfusion or indomethacin or ibuprofen treatment for PDA. And this is one of the topics I was requested to talk today. In Japan, routine use of glycerin enema is widely applied to promote meconium passage and to prevent feeding intolerance. Meta-analysis was reported in 2015, but the preventative effect of enema on neck feeding intolerance or other gastrointestinal dysfunction is not proven. And there's no definite consensus on the detailed procedure, such as the timing of start, dilution, dose, and interval. In general, we start enema from the initiation of minimal enteral feeding or within 12 to 24 hours after birth, and we usually administer 1 or 2 milliliter per kilogram per dose of 25% glycerin 3 to 6 times daily. Usually, nurses insert Neraton catheter into the rectum about 2 or 3 centimeters from anus and administer warmed enema slowly. As shown in previous slides, the meta-analysis have not proven the effectiveness of enema. One of the large differences is that the volume of glycerin enema used in previous reports, like Hayden, may be larger than Japanese method. But we do not have enough data on the effectiveness of our method with lower dose of glycerin enema. We also use probiotics, and Bifidobacterium breve is widely used in NICUs in Japan. It is potentially expected to prevent neck and allergic disease through stimulating the colonization of Bifidobacteria, upregulation of TGF-beta, and modulating the expression of toll-like receptor 2 and 4. Usually, it is started with the initiation of enteral feeding and used at least until full enteral feeding is achieved or until discharge from NICUs in the longest case. The next topic is human milk fortification. So currently, only powdered human milk fortifier is commercially available in Japan. Liquid fortifier is not available yet. In 1995, HMS1, that is the first human milk fortifier in Japan, was introduced, and HMS2, that is enhanced with the rich nutritional components such as protein, calcium, phosphorus, and lipid, was put into practice use in 2013. Now these two fortifiers are widely used in Japan. There's one problem, one issue that is vitamin and trace elements such as iron and zinc are not added to a human milk fortifier due to legal regulations. If shortage is suspected, these nutritional components should be administered separately. And this slide shows protein and energy intakes needed to achieve fetal weight gain that is proposed by Ziegler. The recommended requirement of protein administered as enteral nutrition is reported to be approximately 4 grams per kilogram per day. In our NICUs at Showa University, this recommendation is set as a target intake for extremely preterm infants during enteral feeding management. This figure shows protein and energy intake with 150 milliliter per kilogram of breast milk fortified with HMS1 and HMS2 based on analysis of human milk components. As you can see, even if full feeding is achieved with full strength of a human milk fortifier, the required protein intake cannot be achieved. Excuse me. So this low protein intake compared to energy intake may cause fat accumulation compared to increasement of lean body mass. To solve these issues, individualized human milk fortification is thought to be necessary, especially for protein. This figure shows the postnatal change of protein concentration in breast milk of mothers who delivered very low birth weight infants in our hospitals. The protein concentration is highest immediately after birth, after delivery, and decrease with the number of weeks after birth. Theoretically, the protein concentration in breast milk should be 2.6 grams per 100 milliliter in order to achieve the target protein intake of 4 grams per kilogram per day with feeding volume of 150 milliliter per kilogram per day. And it is possible to add 1 gram per 100 milliliter of protein by standard human milk fortification with HMS2, but this triangle area means a shortage of protein concentration. In order to make up for this shortage of protein, individualized human milk fortification is considered necessary. Individual human milk fortification is not widely accepted in Japan, but clinical research is ongoing in our institutions. Two methods of individualized human milk fortification is reported to be effective to reach target protein intake. Target human milk fortification is a method in which the amount of additional protein fortification is determined by according to the result of component analysis of breast milk using human milk analyzer. Another method is called adjustable human milk fortification. The amount of additional protein is adjusted to maintain 9 to 14 milligram per dl of blood urea nitrogen level as an index of protein intake. This method does not require a human milk analyzer and can be easily carried out. And this graph shows the progress of the case who underwent targeted human milk fortification in our NICU. This baby was born at 29 weeks of gestation. We start parenteral nutrition immediately after birth and minimal enteral feeding is started. In this case, we had to reduce amino acid volume in parenteral nutrition because of hyperammonemia in day 3. However, we could steadily increase the amount of enteral nutrition, and parenteral nutrition was discontinued at day 10. We started human milk fortification at half strength at day 10, and then the full strength was achieved at day 16. According to the result of human milk analysis, protein intakes at this point was less than 3.5 grams per kilogram per day. And then targeted human milk fortification with protein fortifier was started, and protein intake was maintained between 3.5 and 4.0. At 40 weeks of corrected age, this baby could obtain good growth and extrauterine growth failure was avoided. Recently, an exclusively human milk-based diet using a human milk-derived fortifier has been reported to show beneficial effects such as shortening of parenteral nutrition period, prevention of NEC, BPD, ROP, and sepsis. In the United States, Product Bioscience is the only one company manufacturing human milk-derived human milk fortifier by using process such as ultrafiltration from non-human milk. They have 4 types of fortifiers, and additional proteins and calories can be provided to each infant's condition. So AHMD might be the most optimal nutrition for preterm infants, but the largest problem is that AHMD is extremely expensive, and it is not realistic for parents to pay the actual cost. Currently in Japan, preparations are underway for clinical trials and system to supply AHMD to all extremely preterm infants who needed AHMD. So this is the last slide I prepared for today. And again, the strategies listed here are common practice in Japan, but these are not necessarily evidence-based, and there are large center variations. I hope that what I have talked about today was expected, and it will be useful for all of you. Also, I'd like to know if there is any better care being performed in your countries that we can take into our management. Okay, so thank you so much for your attention. Thank you.
Great, thank you. So if I can ask, yes, you to stop sharing your slides, please, and then we can have the 3 speakers, and My co-chair, John, to turn your videos on as well. Lovely. And the three speakers, and we'll have a discussion because there's quite a few questions, and thank you for submitting your questions through. So over to you, John.
Yeah, so fantastic.
I think we have about half an hour.
Yep. So fantastic number of questions, really, which would really, people are so interested in what you do in Japan. Really, the first question I'll start with is how long you would use your umbilical catheters for. This comes from a Japanese source. I don't have the name. And really, do you try and make it a short duration in these tiny babies in whom you have umbilical artery catheters? And my question will be addressed to, obviously, my question will be addressed to Isamu Hokuto.
Yes.
So I don't know whether that.
Wait. Okay. So first question is about umbilical artery catheter. Is that right?
Yes.
Yes. I think it depends on the center, but we secure USC for 22 to 23 weeks gestational age, but usually remove within 3 days of age. And if the baby needs blood direct blood pressure, we take a radial artery to secure. Okay, so maybe longest period is maybe 3 or 4 days.
Yes, thank you. I have another question, which is coming from Japan also, which is, do you use carnitine intravenously for the purpose of having neonates tolerating lipid intake well in their mitochondria?
Yeah, that is very good question, important problem. But maybe I think many center doesn't use carnitine routinely. But if the baby's condition is very bad and can't start enteral feeding, that situation maybe we use carnitine.
Okay, thank you.
Okay.
That's interesting. Also, Professor Hokuto, do you individualize your parenteral nutrition or do you standardize it? And this comes from Dr. Alifah in Yogyakarta.
Oh, thank you for questions. Maybe many centers standardized parenteral nutrition, but also a very severe case, we use individualized nutrition.
Thank you. That's good. Another question we have from Dr. Uthaya is that there is concern about parenteral nutrition in critically ill adults and children also, as well as surgical term infants or infants with sepsis. Do you, in Japan, gradually increase the macronutrients after birth to try and limit your macronutrient intake? Or is it because you increase your fluids?
I think we increase the fluid if we see the blood volume loss, but usually we didn't add additional fluid, and we don't increase the macronutrients due to each disease. Is that okay?
That's fine. That's fine. I think the other question is one that a lot of people would ask, which is about hypernatremia, given your restricted fluid intake. how do you manage that? Or do you see it with your high humidity?
Yeah, we check the urine output for every 8 hours, and maybe in acute phase we check natrium concentration in blood for about 8 to 12 hours, and usually we don't see so high natrium concentration, but when we see hypernatremia, we just add free water. It depends on the urine output.
Sure, thank you.
If you see lots of urine, we add additional water.
Right, thank you. And how do you manage, there are studies from PICUs report that amino acids affect immune cell function. If a baby's ill, would you choose to give the minimum amount of amino acids and lipids, or cease them, or would you continue?
No, yeah, I think many centers just continue amino acid or lipid, but maybe some center afraid of exacerbation of infection. Lipid is decreased to minimal.
Yeah.
Yeah.
And so I have another question for Dr. Kinoshita. They're talking about 1 gram per day of lipid is the essential amino acid supply. And we know that the omega-6 and omega-3 or omega-6 balance is not ideal. And looking at the differences between the US and Europe and yourselves with lipid, certainly, you have a lot of omega-9, the oleic acid. And so what do you think there's a factor there in promoting inflammation in the gut due to arachidonic acid? Hard question.
It's a good question, but yeah, I have no idea because we only have soybean derived lipid product. So I don't know. Sorry.
Thank you for your honest answer. Do you use acetate? This comes from Dr. Sukarja. Do you use acetate regularly as maintenance requirements in your parenteral nutrition? We use it here in Australia.
Yeah, that's a very good question, but we don't have acetate product in Japan, so it's very big problem. Yeah, we want add the acetate to maintain the blood gas, maintain natural result.
Yeah, sure. Yeah, very good. And the other question we have is, do you have a different enteral feeding guideline? This is for Prof. Ms. Zawa from Dr. Anne Graney in Europe. Do you have a difference in your feeding guidelines for appropriate for gestation or for small for gestation babies?
Okay, actually we do not have any different guidelines or protocol for SGA infant, but severe SGA case may show some symptoms like mechanism-related ileus. So we have to take care to advancement of feeding volume, and in severe SGA case, we will wait until the mother's milk is obtainable. So in these cases, the human donor milk is very, very important, we think.
Sure. I think we
Can
would
I
agree.
comment? Sorry, can I come in there? When you say human donor milk, I suppose what is your actual proportion of babies given human donor milk? Because I understand it's not that common in Japan. Is that right?
I'm sorry, I couldn't catch.
So the use of human donor milk has not really been very common in Japan.
Mm-hmm.
Is that right?
Yes,
so,
it's not common yet.
So how long would you wait for your maternal milk? This is something that we often talk.
Okay, that's depends on our centers, but we usually wait maybe 2 or 3 days, maybe up to 72 hours after birth. So if the mother's milk cannot obtainable, maybe we will start an artificial formula for low birth weight infant rather than fasting.
Okay, thank you. Can I come in there, John? I'm just dying to ask these questions about glycerin suppositories because it's something I'm intrigued with, and certainly a lot in the chat. And we've just been talking about, waiting for mum's milk, and also we often wait for the bowels to open. And there are several questions here from different people about, your protocol for when you give glycerin suppositories. When would you not give it? And how regular do you expect your bowel motions, for example? So have you got a protocol to when you would give the suppositories or not the suppositories?
So that's to
question to Dr. Miyazawa, I think. So we use we do not use suppositories. We use, so this is
enema.
Satoshi. We use enema.
Okay, sorry.
Enema.
And do you have a protocol for using or not using the enemas?
No, maybe there's no protocols for the use of enema, but most of Japanese neonatologists prefer to use, and that's almost routinely used and very widely used. So in most of the cases, we start the enema maybe within 12 hours or at least in a day after birth with a small amount.
Sorry, you use it within 12 hours of birth?
So
yes.
within actually immediately after birth, maybe
Right.
our nurses started glycerin enema.
Okay.
Otherwise we stopped to do that. Nurse can do by themselves. Nurses, yes.
Do you even prescribe? There's another question in the chat about, do you even prescribe it, or is it actually just a part of routine care?
Kind of routine care.
Right. So it's not even, you don't even have to prescribe it. So is that given, do you expect a bowel motion every day? Would you give it, how often would you give it to aim for what frequency?
So several times a day, sometimes 3 or 4 times a day. So nurse can actually estimate, nurse can judge how often the baby needs glycerin enema. So
and how does she judge? How does the nurse judge?
So once she tried first enema,
maybe the nurses check gastric regional volume or abdominal distension, and well, Dr. Kusuda talks the nurse perform the enema with the prescription, but in our hospital we have to prescribe enema, and we decide the timing and the dose of the enema.
And so, you are aiming for bowel motion every day, I suspect.
Yeah, every day.
Yeah. Okay. Well, John, do you do that in Australia?
So we don't do it routinely, but we have started to increase to do it, and we've been really interested in the fact that the Japanese use diluted glycerin, and use a small volume, which we've also been doing as an enema. So it's what, and the question going on from that is Nina's raised, which is would you in Japan consider doing a randomized trial of glycerin?
Yeah.
Actually, all infants received enema, so it's very difficult to randomize.
It's hard in Japan.
Yeah.
Maybe the rest of us.
I think so.
But yeah, I find it intriguing. I mean, in the UK, we use suppositories, but there's no protocol for it. And we often debate about the size of suppository depending on the gestation. So, I mean, the question from Dr. Uthaya says, what is the volume of the glycerin enema? Is this titrated depending on the size of the baby? Dr. Miyazawa?
Yes, I showed the slide, and the volume of the glycerin enema is about 1 or 2 milliliter per kilogram per day per dose. So we use the enema for maybe 3 or 6 times a daily. So the previous study uses glycerin enema with more large volume, so it might be the big difference.
Yes, and there's a comment here about maybe it's the frequency, the low volume frequency, which is the key. And certainly, as John said, and Professor Modi and many on the chat says, that's clearly, definitely rationale for a RCT. And I do understand that meta-analysis previously published had quite low sample sizes, didn't it?
It
so
did.
Perhaps that is something we can take offline. And anyone on the call wish to join, please do place your comments if you're interested. Over back to you then, John.
Sure, no, thanks. And so the other question is really Nina's raised, which would you, as our Japanese colleagues, be prepared to consider joining a multinational RCT trial of pasteurized human donor milk versus formula as a supplement when mother's milk is insufficient?
Yeah, that's also a very important issue. So yes, we do not use donor milk much here in Japan. So in this situation, yeah, we can do kind of randomized controlled trial. So I agree with Nina.
I think that's a yes, Nina. You got another international partner. Great. Can I touch upon the question about probiotics? So I presume that's just routinely given in Japan.
And that particular probiotic is Japanese, used universally in Japan, Bifido bacteria.
Yes, it's Bifido.
We use Bifidobacterium burete that is commercially available, so we use it.
A question around that was whether you've seen a change since you started using the Bifido. You've been using it for a long time now, haven't you? Did you see a change in NEC with its introduction?
Maybe there was some trials in past. So, but in Japanese trial there was probably has some difference, but the incidence of neck itself is very low, so it might be difficult to it's really effective to prevent neck.
Yeah, and I guess, for the UK, the PIPS trial used the same strain, and I guess, we didn't find a difference. So, I know the latest SBN guidance is proposing other probiotics and other combinations. That's certainly still an uncertain area for us in the UK.
And so people are thinking about looking at genetic differences in susceptibility to NEC. Are you doing any of that in Japan? That's from Nina again. I don't know who I address that to. All of you, I think.
Yes,
so,
it's long.
Okay. So maybe I can come. Actually, in Japan, before starting probiotics, NEC is not high that time. So we didn't see any effect to prevent NEC itself by using probiotics. However, right now, I think almost 100% of Japanese NICU using some kind of probiotics. So it's very difficult to see the benefit of using the probiotics to actually prevent the NAC.
Right.
Yeah, so that's interesting because obviously, we're all worldwide trying to tease out what exactly in Japan are you doing that's, influencing your low NEC rates. Is it just genetic susceptibility, or is it one of your minimal enteral feeding, your probiotics, your glycerin enemas, or your, fortification? We don't know, essentially. So that's why we're asking these questions.
So we also don't know. Actually, we are very careful to start enteral feeding, and also we are very careful to increase the amount of enteral feeding. So that may help. That may actually prevent the inflammation of the bowel of preterm infants. And also, I think we try to use all mother's milk very early phase. So that maybe prevent the NEC. And also, as I said, already most of, or maybe all NICUs in Japan use probiotics. That may help. I understand UK study didn't show the benefit to prevent NEC, but we believe some part it helped. So it's a so it's a kind of comprehensive effect, not only one silver magic.
Yeah, your mortality and morbidity and your NEC rate's been so low for so long. I can see why you're saying this. And a question I have for you is, I'm interested in your management of the fluids and looking at the filling of the IVC and the SVC. How long have you been doing that in Japan? That your very high humidity in your ultrasound monitoring of adequacy of blood volume.
Is this my question? Maybe.
Yeah.
Usually, we check very close monitoring for 3 or 4 days. So in some center, check 3 or 4 times a day by ultrasound.
Yes.
In my hospital, many doctors check the blood volume or cardiac function once a day. It depends on the center.
And how do you respond to low blood volume?
Well, just the saline, normal saline, and after that, increase the total fluid therapy volume.
Very good.
So can I comment this issue? This is Satoshi Kusuda. Can I comment?
Sure.
I think still you are misunderstanding our policy to restrict the fluid intake. We do not restrict the fluid intake. Actually, we reduce the evaporation from skin. We reduce insensible water loss under high humidification condition. In that way, we can reduce the amount of fluid infusion. So it's not our target, it's actually result of reducing reducing
I
the
think
insensible water loss. So in that way, we can reduce the water intake, and also we are very slow to start intravenous hyperalimentation because we are starting very low volume. So it's a just result. We are not intend to restrict the water infusion at the beginning.
Sure, I appreciate that. That high humidity seems to be key. Yeah, yeah.
Yes.
Yes.
So I think we're running out of time, but we still have more questions, and we really trying to we so appreciate your contributions and your talks, and there's not really time to answer all the questions now, but if you send the questions to us, we can forward them on.
Hi, John. John, sorry, it's Julie. So what I would suggest is I will download the text and send it to our speakers. And if they agree, what we've done before is to have them respond on a Word document, and I will post it onto our social media pages.
Great, Julie. Sounds
okay,
good.
thank you. That was a wonderful talk, everyone. I'll let the chairs wrap it up. Thank you.
Thank you, Julie, and thank you so much again for organising this and inviting us to chair. Just to close this meeting, a huge thank you to our three speakers. Excellent talks and very fascinating. You've really given us insight into the practice in Japan, and we're still really uncertain to what which one of those practices reduces your NEC rates. But it's really good to share these practices internationally, and we will continue the discussions offline. And certainly we have taken all these questions and hopefully we'll be answering them. So, and thank you to everyone who joined today and posted a question as well. It's great to
I would go along with that too. And we are so grateful to you for giving your time to us to learn some of the secrets of Japan. We want to find out more.
Absolutely. This is just
we want to see in person and to discuss.
Hopefully soon we will be in 3D and we can all meet rather than
3D version.
Great. Well, on that note, we'll say goodbye to everyone and hope you have a very good day and stay safe. Thank you.
Thank you.
Bye-bye.
Bye-bye. Thank you.
you.